Good morning, student. We'll continue topic nutrition. Today's competency 8.3 and subtopic or topic is protein energy malnutrition, where mainly we are focusing on two main types of malnutrition, that is Kwashiorkor and Marasmus. Apart from, we are also seeing some other types of protein energy malnutrition diseases. So protein energy malnutrition disease is the most widespread nutritional problem in developing countries, predominantly affecting the children. The prevalence rate varies from 20 to 50% in different areas depending upon the socio-economic status and level of education and awareness. At one end of spectrum of malnutrition is marasmus, and at other end of spectrum is Kwashiorkor. Marasmus means Greek word meaning to waste. Here, due to continued severe deficiency of both dietary energy and protein is there. That is primary calorie deficiency and secondary protein deficiency. So in marasmus, protein as well as energy deficiency is seen. But Kwashiorkor is different. The meaning of Kwashiorkor is sickness of older child when a baby born in that family. That term is a local term language of Ga tribe of Ghana. So they have observed that when a new baby born in the family, the older child will have this disease. Therefore, they have named it as Kwashiorkor. Here, due to isolate deficiency of proteins along with adequate calorie is seen. Here, calorie is adequate, but it is protein deficiency disease mainly. So, these are various types of protein energy malnutritions according to WHO, World Health Organization, on the basis of body weight as comparing with percentage standard body weight. First is Kwashiorkor and then marasmic Kwashiorkor, marasmus, nutritional dwarfism and underweight childhood. So they have 5 these different diseases and they have compared 3 factors. First factor is percentage of body weight of that person as compared to standard weight. Then they have next factor they have considered is edema, and lastly Kwashiorkor percentage of body weight is 80 to 60% as compared to standard weight. Edema is seen. Deficiency in weight for height is also seen. Next, marasmus Kwashiorkor. The percentage of body weight is less than 60% as compared to standard. Edema is present and deficiency of in weight as compared to height is marked. Third type is marasmus, where percentage body weight as compared to standard is less than 60%. Edema is not seen, but deficiency in weight for height is marked. Fourth type of protein energy malnutrition is nutritional dwarfism. Percentage body weight is less than 60% as compared to standard. Edema is not there. Here deficiency in weight as compared to height is also not seen because the patient is dwarf or height is less. And last category is underweight, where percentage of body weight is 80 to 60%. Edema is not there. Deficiency as in weight for height is also not seen. So these are various types of protein energy malnutrition diseases according to WHO criteria. Now, what are the causes of protein energy malnutrition? Poor socio-economic status. The parents will not able to feed the baby adequate quantity of food or good quantity of food which contains various components like high class proteins, vitamins, minerals, etc. Lack of education. It is observed that the patient's parents with less educated have their children suffering from these protein energy malnutrition diseases. Next is lack of awareness about the disease. So many parents, when this patient is suffering from this disease, they don't think that it is a disease because they are not aware. Then lack of awareness about the nutrition. So uneducated parents does not know how or does not have the knowledge of nutrition, or they does not have knowledge of importance of including a balanced diet. Next factor is early marriage of girls and early pregnancy. When the mother body is not fully developed, the developing fetus will get less nutrient from the mother. Next factor, lack of care of mother during pregnancy. When a mother becomes pregnant, then she should be given proper diet and extra diet for the developing baby, but that point is neglected here. Spacing of two child is less. Here two babies or babies will born one after another with a less gap. In such cases also these babies will not get enough food or nutrient from mother's body because she has also not recovered from previous pregnancy fully. Next factor, underweight mothers. In our countries we have found that many girls are underweight. So such underweight mothers will give rise to a baby which may suffer later on from protein energy malnutrition disease. Early weaning of child. Weaning means here giving the food to the baby, outside food to the baby apart from breast milk. Breast milk should be continued minimum 6 months or more, but here early weaning have started for the baby, means external food is given. Therefore this external food causes many foodborne diseases like bacterial and viral infections, loose motions. This may also aggravate the protein energy malnutrition disease. There are some social beliefs in various religions which may also causes protein energy malnutrition. Repeated infections like diarrhea, respiratory infections are also contributing to the protein energy malnutrition disease. Now this is the difference between Marasmus and Kwashiorkor. Age of onset generally for Marasmus is below 1 year and for Kwashiorkor it is 1 to 5 years, but this is not an absolute criteria. Next, primary deficiency in Marasmus is of calorie deficiency, whereas in Kwashiorkor it is protein deficiency. Causes of Marasmus may be early weaning and repeated infections. In Kwashiorkor, the parents will often give starchy diet after weaning. Starchy diet means carbohydrate diet. Protein is lacking because they don't have knowledge of balanced diet, which precipitated by acute infections. If such patient have acute infection, then it will again worsen the condition. If you compare the attitude of child, in case of marasmus, it is irritable and fretful, whereas in Kwashiorkor, it is lethargic and apathic. Appearance in marasmus is shrunken with skin and bones only and dehydrated. Whereas in case of Kwashiorkor, baby looks plumpy due to edema on the face and lower limbs. Skin of marasmic patient is dry and atrophic, whereas in case of Kwashiorkor, the skin is greasy pavement dermatitis due to peeling, cracking and denudations. Hairs in marasmus, no characteristic changes, but in Kwashiorkor, hairs are sparse, soft and thin hairs. Curls may be lost. Associated features include in marasmus, along with calorie deficiency, some other nutritional deficiencies are also seen. Watery diarrhea may be there in the patient. Muscles are weak and atrophic. In case of Kwashiorkor, angular stomatitis, cheilosis are common. Here also patient have watery diarrhea. Muscles undergo wasting. If you compare the serum albumin of the patient, in case of marasmus, it ranges from 2 to 3 grams per deciliter, which is less than normal. Whereas in case of Kwashiorkor, it is less than 2 grams per deciliter. If we compare cortisol level is increased in marasmus, whereas in Kwashiorkor it is decreased. So these are the differences between marasmus and Kwashiorkor. Now if you want biochemical alterations, so these are the biochemical alterations in protein energy malnutrition. First is hypoalbuminemia. Albumin values is less than 2 gram per deciliter and it is a biochemical marker of Kwashiorkor. Whereas in marasmus, albumin level ranges from 2 to 3 grams per deciliter, which is not normal. It is also less than normal range. Next is IgG, immunoglobulin G, increases due to associated infections in both cases. Cortisol level increases in marasmus and decreases in Kwashiorkor. After seeing the biochemical alterations, we will come to the treatment of protein energy malnutrition. First is diet. Calories 150 to 200 kilocalories per kg body weight should be given to the patient suffering from PEM. Along with calorie, protein should be given. The protein should be from 3 to 4 grams per kg body weight. So this much quantity of protein should be given to the patient. It is monitored by disappearance of edema, rise in serum albumin level and gain in weight. That means as we give this patient, so these changes appears. These 3 changes. First, edema disappears, serum albumin level increases and the baby will get, or the child will get the weight. Now for a protein requirement, we have to take a mixture in which 3 parts of vegetable proteins, which may be coming from any grams, for example Bengal gram or peanuts, and 1 part of protein should be taken from milk. That means if 40 grams of proteins are required, then 30 grams should be taken from vegetable proteins and 10 grams should come from milk proteins. Severe malnutrition in early life can lead to permanent and irreversible physical and functional deficit. So these are the effects of protein energy malnutrition. Severe persistent malnutrition may have deleterious effect on intellectual capacity in later life. Moderate to mild forms of malnutrition, if corrected in time, they have not any consequences. So, since the children of today are the force of tomorrow. A nationwide effort is to be made to eradicate this childhood malnutrition. So, this is about the protein energy malnutrition. Thank you very much.